such a nice lecture. This is a unusual topic and often very neglected aspect of patient care. Sexual dysfunction in liver diseases. So these are the issues that we need to discuss. How to define sexual dysfunction, how to evaluate patients, what is the prevalence, what are the associated factors, and what are the mechanisms, what is the effect on quality of life, because ultimately we are focusing, we want to improve the quality of life of our patients, and how do we manage this, and how does it behave after liver transplant. So male sexual dysfunction includes a range of conditions which include from low libido, erectile dysfunction, ejaculatory and orgasmic disorders, Peyronie's disease, and again there are subclassifications based on the various mechanisms. Now this is female sexual dysfunction. Again there is a range of conditions. We need to dissect which aspect of sexual dysfunction is affected in a particular patient. Low libido, arousal disorders, there could be orgasmic issues, there could be painful intercourse, dyspareunia, vaginismus. These are the problems. So how do we evaluate a patient? So first, history and physical examination. We have to listen to the patient. We have to devote some time with the patient. So sexual history should be very detailed. There are questionnaires that we will see, and involved partner with that. Medical history is very important. Age is one of the factors. Diabetes, hypertension, obesity, medications. Many medications used in cirrhosis can contribute to sexual dysfunctions. Smoking, alcohol, these are all contributory factors. And psychological assessment is very important. Anxiety, depression, stressors, relationship problems are all contributory to each other, and we must involve other departments like psychology or psychiatry department also. Physical examination, if there are any local deformities, prostatic disorders, hypogonadism, CNS, CVS, neurological examinations, these are very important. For male, these are, the first is the International Index of Erectile Functional Questionnaire. This discusses over past 4 weeks. These are the areas that need to be assessed: erectile function, orgasmic function, sexual desire, intercourse satisfaction, and overall satisfaction. And based on the overall score, if the score is less than equal to 25, then it is erectile dysfunction, and then according to severity we can grade. For example, between 6 to 10 it is severe, 11 to 16 moderate, and 17 to 25 mild, 26 to 30 is normal. So this is one questionnaire, IIEF. This is the shortened version of the same, IIEF 5, only 5 questions. And in this, if less than 21, it is called erectile dysfunction, and then subsequently it can be quantified according to the severity. For female sexual function index, again over past 4 weeks there are questions assessing sexual function domains, and in this total score less than 55 is female sexual dysfunction, and for each domain there are specific cutoffs, so that there could be specific domain disorders also. And this Arizona Sexual Experiences Scale, this can be used for both male and female. This assesses questionnaire over the past week. Previous questionnaires were past 4 weeks, now this is for past week. And there are 5 questions and score ranging from 5 to 300. And here higher scores indicate more sexual dysfunction. And again, it can be defined as total 19 or more, it is female sexual dysfunction, or 5 or more on any item, or 4 or more on 3 items. So what is the prevalence actually? So if we looked at the erectile dysfunction, that is male sexual dysfunction, prevalence is quite high. There have been various studies, but there is also paucity of studies. First study on NAFLD, prevalence is quite high, 45 to 67%, and degree of fat correlated with erectile dysfunction. And as we have seen, risk factors were diabetes, hypertension, obesity, and psychogenic. Another study on chronic viral hepatitis, again 14 to 78%, more with diabetes, 92% if they had diabetes, more with cirrhosis, 85%. SCV had more as compared to HBV, and the reason was endothelial inflammation or cryoglobulinemia, that is more common in SCV. And a meta-analysis in patients with cirrhosis, which found that up to 80% of patients have erectile dysfunction, and if it is decompensated, it could reach about 90%. Similarly, studies for female sexual dysfunction, prevalence. One study in chronic liver disease patients with mixed etiology found that reduced sexual desire in 33%, reduced arousal in 18%, difficulty in orgasm 25%, and coital dysfunction in 25%. Similarly, there have been other studies, non-cirrhotic MASLD, hepatitis B, hepatitis C, and patients waiting liver transplant. Again, very quite high incidence of even female sexual dysfunction, but these studies may not be adequately reported, and these issues, because socio-cultural issues are very important, patients may be shy to come up with these problems. So you need to make comfortable the patient so that they come out with these problems. This was one study which was done here in hepatology department. This was on male 21 to 60, cirrhosis of any etiology and high performance status. So of 400 patients, 72.3% had erectile dysfunction. This is quite high. And almost half of them had severe ED, or there was no attempt at all. So 70% had erectile dysfunction, and of those 50% has very severe erectile dysfunction. Now, what are the associated factors and mechanisms of sexual dysfunction? So these are the associated factors: overall health status, age, diabetes, hypertension, mental status, depression, and anxiety. And in this study, majority of the patients with ED had generalized anxiety disorder and major depression. This was done at ILBS hepatology department. So GAD-7 score, which indicates anxiety, almost half of the patients, and PHQ-9 score, which indicates severe depression, again about half of the patients. 50% of the patients have anxiety and depression. Now, severity of chronic liver disease. So in the same study, if CTP-C is there, 90% prevalence is there, CTP-A about 65%, CTP-B 72%, and CTP-C 90%. So it increases with CTP scores. And multivariable analysis of factors associated with ED showed that age, duration of cirrhosis, CTP status, even baseline HVPG, baseline prolactin, anxiety, depression, and DEXA ASMI, that means muscle skeletal mass, is also important part. Now, what are the mechanisms? We have gonadal dysfunction, decreased testosterone, decreased free testosterone, increased estradiol, increased prolactin, drugs, toxin, medications, insulin resistance. We will discuss one by one. So in this study done at ILBS, multi-factor, multivariable analysis. This I have discussed. Okay, this one. So in this study, it was found that total testosterone was low, free testosterone was low, LH was higher, and prolactin was higher among patients with erectile dysfunction. So hormonal imbalance also plays a role. Now, drugs and toxins. Alcohol, non-selective beta blockers commonly used in cirrhosis, spironolactone, immunosuppressants like azathioprine, tacrolimus. These are the drugs that can commonly associated with erectile dysfunction. Insulin resistance, ER stress, vascular endothelial dysfunction, arteriosclerosis, oxidative stress, inflammation, apoptosis, anemia can itself lead to erectile dysfunction. These are some of the correctable factors. Now, effect on quality of life. So in the same study from ILBS, we found that patients with erectile dysfunction have poor quality of life across all the domains. This was done using SF36 version 2, and across all physical functioning, role physical score, bodily pain score, vitality score, overall scores, physical and mental, all the domains were affected and led to very poor quality of life among patients. As far as the management is concerned, this algorithm is for sexual dysfunction in chronic liver disease. Risk factor management is very important: alcohol, smoking, obesity, medications, diabetes, control lipids, control diabetes. And if there is erectile dysfunction, then assessment, psychological assessment is very important. Then phosphodiesterase 5 inhibitors, sildenafil, tadalafil can be used. If erectile dysfunction with low libido and we find that testosterone is low, then besides psychosocial interventions, testosterone can be used, injectable or topical. But it is a multidisciplinary management, and we might need referral to specialized management for patients requiring vascular, neurological, cardiac, pelvic, perineal, penile surgery, and so on and so forth. This is management algorithm for female sexual dysfunction. Again, first risk factors. Then if there is low libido, then there is, after psychosocial interventions, then there is a drug, bremelanotide. This is a melanocortin receptor agonist, FDA approved, but there is no safety profile in cirrhosis, so we cannot say whether we should use it or not. If there is a pelvic floor dysfunction, then we have to assess and manage accordingly with referral to urogynecologist and so on. This was the study done at ILBS with, by Rakesh Jagdish. Tadalafil for erectile dysfunction in cirrhosis. He included patients with erectile dysfunction. And please note the exclusion criteria. CTP more than equal to 10 were excluded. And obviously, we have to evaluate cardiac for unstable angina and other things before we start. So tadalafil dose was 10 milligram versus placebo. And this improved erectile dysfunction at 12 weeks of therapy across all the domains. And as we can see, erectile function and orgasmic function, sexual desire, everything, on every domain, it improved after 12 weeks of therapy. It also improved anxiety and depression scores at 12 weeks of therapy. And obviously it improved the SF36 quality of life scores, including the mental component of summary score. Obviously physical component of the summary score did not improve because mental component is more important. Importantly, there were no adverse effects on HVPG at 12 weeks of therapy. Baseline HVPG was similar, and at 12 weeks also, delta HVPG, delta decline more than 20% and HVPG less than 10, all were similar in both the groups, tadalafil versus placebo. And there were no major side effects of tadalafil. However, as the side effects are of low incidence, so larger studies would be needed to evaluate for rarer side effects. Now, effect on liver transplant. So post liver transplant cross-sectional studies are there which show that males have more severe sexual dysfunction. Sexual suffering affects more men as compared to women, and liver transplant recipients were less satisfied with orgasmic strength, and quality of life and sexual function improved in both males and females post liver transplant. And similarly, erectile functions, some studies have shown that in about 50% it is improved, in some patients it worsens, and in some it remains unchanged. This was a study done by surgery department by Dr. Raj Gopala under Professor Pamecha, and this study was on 98 patients. Ultimately 62 were included after the inclusion criteria and evaluated at 3, 6 and 12 months. two scores were used, SX score and IIEF 5 score. So etiology, obviously NASH and ethanol were the most common. Now post liver transplant, SX was declining. That means the sexual function was improving. Similarly, IIF scores were increasing. That means the sexual function was improving, and the scores are continuously growing up at 3 months, 6 months and 12 months. Similarly, testosterone levels post liver transplant were also increasing from pre-op 3 months, 6 months and 12 months. Now sarcopenia came out as an independent predictor of sexual function post liver transplant, as we can see with p-values of 0.002, and there were other factors like BMI and MELD which were also important. So in sarcopenic patients, the testosterone recovery was less as compared to the non-sarcopenic patients. So this would be an important factor, because the sexual dysfunction recovery depends on patients whether they are sarcopenic or non-sarcopenic. So to summarize, both male and female sexual dysfunction are very common in chronic liver diseases. They are associated with poor quality of life. There are multiple associated factors and mechanisms involved. Detailed history, questionnaires, physical examination, assessment of associated factors, drugs, psychological factors should be done, and a multidisciplinary approach should be taken: hepatology, psychology, psychiatry, urology, endocrinology, etc. And ED may improve post liver transplant. So liver transplant is always a consideration whenever indicated. Thank you very much for your opinion.